So we have 3 physical therapists today that are going to talk about kind of common physical therapy themes, switching gears from orthopedics. I think we're related, but have some slightly different topics that we commonly discuss with our families. Ooh, this is fancy. I didn't know all these were in here. Build the suspense. These are the 3 of us that will be talking today. Maybe. Okay. So, Lindsay Alfano, I work at Nationwide Children's Hospital in Columbus, Ohio. Our physical therapy team sees patients in our neuromuscular clinic, so we get the fun opportunity to solve all the individual problems that come through the door and help figure out that puzzle. We also work on clinical trials in our neuromuscular patients. So whether these are first in human or industry sponsored trials, we're the ones doing the efficacy assessments to see if treatments are working. And then we also do our own research. So we hear you when you come into clinic and you tell us what's working, what we're missing. And our goal is to really develop outcomes that are meaningful, consistent, and measure change over time to make our treatments, to make sure that we're measuring improvements in treatments as they are there. Mariana, I'll pass it off to you. Maybe.
Thank you.
Nope. Yay.
Okay, I'm Mariana Altiherio. I'm a Brazilian physical therapist, and I'm, oh, sorry. Okay, I think it's better here. I've been working and studying with congenital myopathies and dystrophies in the last 10 years, and I hope to contribute to this session. And let's introduce Minal.
Hi, everybody. Can you guys hear me?
Yeah, I think we have Minal online.
My name is Jain. I'm a physical therapist at the NIH. I'm sorry I'm not able to join you guys there, but I also, like Lindsay, we work with kids and adults with muscular dystrophy and involved in research. So hopefully we'll be able to answer some of your questions. And again, good luck to everybody at the conference.
Okay.
All right. So we'll see. All right, so to frame our discussion, we have a few slides, but really we wanted to open this up to questions because there is no one size fits all. So there's not a particular exercise regimen or stretching regimen or equipment regimen that everyone needs. It really depends on you or your child and your unique questions. So you all get a gold or platinum or whatever is the best medal right now. Star, you are here, so you are doing great. You are doing things, you're actively involved. So just know you are absolved of all guilt. Sometimes you hear things that, you know, this person's trying this or this person's trying this. Again, there is not one thing that is perfect for everyone. So what you are doing is great. And if you do need support, reach out to your team and we'll find ways to support you there. So don't feel like as we go through some of these that you must be doing every single one of these things or you are not doing everything you can. If you are doing every single one of these, that might be too many things. So keep that in mind. So the role of the physical therapist, I'm sure you are all familiar with us, but in case no, we are monitoring range of motion, looking at contracture progression. We're also talking about exercise and activities, thinking about your home environment, the school environment, work environment, all of the environments. We also want to know about pain. So just because you have a diagnosis does not mean you have to live with pain. So please be vocal. Tell us if things hurt. We also talk about positioning, seating management, as Dr. Roy was talking about. There's also respiratory therapy, which depending on your geographic region is either managed by a physical therapist or sometimes you have a respiratory therapist on your team as well. Really, our goal is to make sure that people are maintaining independence, dignity, able to do what they need to do and be successful in all facets of life across these disorders. So what we are going to talk about today, these are our 3 main topics. So I'm going to kind of start with exercise and activity recommendations again at a very general level. Then we'll have talk about contraction management and then everything else, wheelchairs, equipment, bracing, things like that. So being honest, so starting from a place of honesty, we do not have a lot of great research in exercise and neuromuscular disorders. Randomized controlled trials are really hard to complete. So everybody is a unique individual. What is the appropriate dosing for each person is different. So we often fall back to our, American Heart Association recommendations. We want you doing 30 minutes of activity, maintaining that active lifestyle. But there's not really something to say, again, you need to do this on Monday, Wednesday, Friday, this on Saturday, and then you will be living a healthy life. Most studies are kind of lower levels of evidence. We usually fall back to the paradigm that submax training isn't necessarily harmful. It's probably beneficial, but we do want to avoid overuse or really powerful movements. So what we call eccentric contractions. So with your muscles, there are kind of 3 different contractions we talk about. So there's the concentric one where you think about when you're lifting weights. So your muscle is contracting as it's shortening. There's also an isometric, so your muscle is contracting while it's not moving, it stays in the same position. And then there's the eccentric contraction where it's contracting while it's lengthening. And that requires a lot of muscle power and control. And we often see more muscle breakdown with those eccentric contractions than we see with other movements. Your body uses a variety of concentric, isometric, and eccentric contractions all the time, so you can't prevent them. But this kind of increased power and muscle damage that occurs with those is why we don't often recommend things like bicep curls or, going to do weightlifting at the gym. From an aerobic perspective, we typically consider kind of a use it or lose it model or paradigm. So we want people to move and be active. If you just sit on the couch all day, everybody's muscles atrophy. So we do encourage patients to move. There's some research in a particular subtype of limb girdle to show that doing cycling or kind of a low impact aerobic activity can be useful to improve oxygen intake, overall aerobic capacity without having a negative effect on lab values. But we do see in other forms of limb girdle muscular dystrophy that there's a correlation with patients that did really intensive high school activity in their teenage years had an earlier onset of that disease or symptom onset. So we have these scales. We want people to be active, but we want to avoid overuse and that muscle damage. And again, this balance is different for everyone. So aerobic exercise seems great. We have inspiratory muscle training for some of our patients can really improve pulmonary ability. We want to avoid those really powerful eccentric muscle contractions and high resistance strength training. Exhaustive maximal exercise, which can sometimes occur during very fun times, like swimming at the pool with your friends. Kids often forget that they're getting tired, so it's nice that there are those mandatory 15-minute rest breaks every hour, or going to Disney World is a very exhaustive activity, so trying to manage those. Don't go to Disney World every day, might be too much, but really more research is needed and across different subtypes and diagnosis groups, because what the findings we find for one doesn't necessarily apply to the other, but we do try to pull all of that information together to make the best recommendations in the moment. So some of the activities we recommend for our patients are walking, if that's something that's safe. It doesn't have to be marathon running, but even taking just regular walks around the block is activity. I often talk about walks even with our patients that use wheelchairs for independence. So managing that wheelchair in an outdoor environment, going across bumpy gravel at the park, going around turns, it's all causing kind of perturbations to the trunk, and patients are working their muscles. So don't just consider this a ambulatory sort of activity. Family walks are fun no matter what they look like. Biking can be a fun activity sometimes. A lot of our patients have used kind of arm ergometers, and that's their activity of choice. Swimming is our favorite activity because it's safe. You can really get your muscles working, even in the presence of some significant muscle weakness, and get that heart pumping. But again, it is so fun that sometimes you can do too much. So make sure you're monitoring that activity. So really, we want to make sure that we're assessing your muscle strength, function, and changes over time, and we can manage these activity and exercise recommendations as things change. We can work as a team to make sure that we're minimizing any of these orthopedic comorbidities that we're talking about, and maintaining the functional abilities across the lifespan. So again, these are kind of ways we intervene. Oh, I didn't ever take my mask off. But I think Mariana here is going to talk more about some stretching activities. But again, strengthening, if you are going to do that, would be more of an isometric muscle contraction versus those true, really lifting weights. And then just moving your body, being active in the way that your body or your child's body likes to move is our biggest recommendation. So with that, I will shift to you.
Can you hear me? Can you hear me? Oh, okay, thank you. So first of all, I'm very honored to be here today, especially after the yesterday video. So I want to thank you, Rachel, and all Curious MD team for that. And I'm kind of nervous because I'm not fluent in English, but I will try to do my best, okay? So I will talk about the contracture management. And I will talk about this 5 fundamental points that manage the contractures. Okay, so the first of all is the early and proper posturing. Since ever and forever, it should be done to prevent and also to treat the contractures which are already present. And the tip here is to pay attention on the position your kid stays the most part of the time, okay? And the second one is to avoid immobility and disuse, because the muscle weakness is the main cause for contracture onset and worsening. And you parents should have already realized how the contractures worse after long periods of immobilization or even less mobility, as hospitalization or pulmonary infection, for example. And the last 3 points we will discuss while I show you images in the next slides. So the third point is daily stretching, which is based on active or passive exercise. The image shows some examples of simple and important exercise that should be done every day if it's possible, and such as neck, hip, knee, and plantar flexors, which are commonly affected in congenital myopathies and dystrophies. Just remember that they should be done according to instructions made by our physical therapists, okay, and occupational therapists. And additionally, I must reinforce the use of orthosis, which brings us to the next slide. Okay, the fourth point can represent a real challenge to families and children. However, it's really important to try to use the orthosis at night, which is strongly recommended, or during the day to provide joint stability and functionality. Here we can see some examples of bracing that you're probably familiar with. And the recommendation will depend on the kid's needs and the specific goal of the bracing. And finally, for an ideal treatment of the contractures, let's move on to the fifth and last point, sorry, the encouraging of standing position and walking. And here we have some possibilities of equipments which are used to manage the contractures, to prevent spine deformities, to position the joints and stimulate the bone development, and also to maximize the functionality. So the takeaway is, the more you keep attention to these 5 points together, the better will be the evolution of the contractures. But even with all this great care, have you ever wondered why surgery can be suggested? Or what are the criteria we physical therapists take into account? So let's see. These are the situations we will consider, we will take into consideration. And when the conservative treatment isn't enough. So, for example, when walking is possible, but hindered by an orthopedic deformity, as you can see in the video. So the hip shortening, the hip flexors shortening of his kid, the kid, it's hindering the walking ability. So we have to consider the surgery management for her. And the other ones, when walking is increasingly difficult due to disease progression, or when walking is not possible, but the ability to stand should be preserved. And finally, when sitting is painful, or sitting the patient is difficult. But now we're gonna continue with Mina online.
Can I ask a question real quick? Because you talked about standards. What do you recommend when the child hates stretching and hates the standard?
Okay, so I don't know, Mina will finish the presentation. It would be better.
Let's just answer this question real quick, because we were just talking about standards.
Okay, sorry, can you help me? I don't understand. I didn't understand what you said.
When kids hate the standards or hate stretching, as most kids do, what do you recommend?
Oh, okay, so sorry, I had to ask Lindsay because I didn't understand the question, Rachel, sorry. So when the kid hates the standing position, okay, so we can provide the standing position with their toes, and we can do this without this standing frames, for example. But I think, in my experience, every kid wants to be in the standing position, but the first moment is very difficult. So maybe it's painful because it stretches the muscles, and even their toes to the first moment we put their toes in the children. It's not comfortable. It's not physiological. So I don't know. I think it's a process. I had this problem recently with pneumolenic myopathy children, and because she's 3 years old and she has never been in a standing position. But I will try to talk to him, to her, and join other kids, and I try to incentivize some activities with other ones. So and I told the family, okay, so now when she's in the same position, let's celebrate. So when I put her, she's crying, but everybody's So after that, she started liking the position. So I think one of our job is trying to incentivize, So I think I will be in this way, I will try to do this like this.
I would just add to that, that I think, again, the one size fits all, or doesn't fit all approach is that, you know, sometimes that positive reinforcement is huge. Sometimes there's, you know, an activity where you can distract the child. Maybe that's when they get screen time. So it's the more fun thing. You'll also find sometimes the standard, even though you've done your best, is not the favorite. And so trying to find ways, you know, it's a spectrum of stretching. So if you start with no stretching all the way to what you're in a stander for 8 hours a day, which I wouldn't recommend for anyone because children like to move and not be stuck in a static position. But let's say that's the extreme end, or positioning is probably better at that end of the spectrum. The more time you're spending in that elongated position, the more we would expect that to have an impact on range of motion. So whatever that combination is if it's a standing frame, if it's use of orthoses, if it's positioning in the wheelchair with leg elevators so you can stretch out those hamstrings, whether it's some other fun combination we come up with, finding that kind of unique way to stretch and keep that positioning for a prolonged period of time is what's likely to be more effective than just a quick stretch in the morning for those. So it is an ongoing process of incentivizing and finding that perfect solution. Hopefully that helps.
Sorry.
And then we'll shift to Mina.
Hello, everybody. So
Oh, yeah.
can you guys hear me? Can you hear me?
You're good.
Okay, sorry. So I'm going to be piggybacking a little bit what Mariana was talking about in terms of devices. And so this is just more of these are some other options. And one thing I forgot to include on one of the slides, and I've put it in the chat box that you can give it to everybody in terms of there's it's called passitoncenter.org. It's an organization that aggregates all lending libraries and equipment donation sites. So this website is run through the Georgia Tech University. And what you could do is go to go to that website, go to your state, and it'll tell you in your state which locations will accept donated equipment, and then you can request, like ask for donated equipment that your child has outgrown, or child or adult has outgrown. Some centers have wheelchairs, some don't. So it's just another place that you can look for equipment if needed. Anyway, so we talked about standing frames, and there's a multitude of them out there. Some are just static standers. Some are mobile standers where they're just upright and that big wheels. And then sitting options, there's multiple seating options that's available for people to use, kids to use. And the most important thing is that you need to have a variety of different positions through the day. If you think about ourselves, we're standing, sitting, walking, lying. So it's unfortunately, you end up having like a hub of lots of equipment, because we do recommend you need to do a little bit of time in the stander. You need to have a little bit of time in a floor sitter. You need to be in a chair where you can sit at the table with the parents when they're having dinner with the family. So these are different seating options. This one is in terms of like a floor sitter, corner chair. The other one's a sitting, with a tray in front. So those are some things that may come up in terms of different devices. And then some of the other seating options would be to, like Lindsay said, elevate the legs. So you could be a floor sitter and then keep the legs extended to do a hamstring stretch. And so those are some of the options. Next slide, please. Back to the standing frame. So there's a mobile stander, there's different types of supine stander versus prone stander. And then the next one, so trying to encourage fun and cool activities. So wheelchair sports is a big thing as the kids get older. And as Lindsay said, just going for a walk doesn't mean you have to be ambulatory. You can kind of walk with in your wheelchair, walk with a walker, any kind of mobile device to keep moving. And one of the things that I try to encourage the kids that are old enough and they're allowed to have a cell phone is actually show them how to use their activity trackers on their phone, so that it kind of is, it's something that they can keep track of. Sometimes it is competitive, sometimes it's not. It just depends on the child. But even if you're an activity tracker, you're in a wheelchair, it does track some level of activity. It may not be as accurate, but at least it's give you some sense of, I'm walking this much today, I did this much yesterday. So that would be another way. And then next slide, please. Okay. And then Lindsay talked about respiratory muscle training. So there's a inspiratory muscle trainer. There's use of kinesiotaping. I know some physical therapists have used kinesiotaping for the trunk to help. It does not it does not replace the use of a body jacket for someone for scoliosis, but it does provide some feedback, and it does help some kids kind of sit upright temporary, at least during the session. So it is something that I have known that people have used. I know this picture is showing of a knee, but I have used it on someone on the trunk. And then the other one that is used often that I have seen in young kids are the Spio suits, or the lycra neoprene suits. And the intent is to kind of give the compression for being able to kids to sit up straighter. There's not a lot of research to show that it's helpful, but there's not a lot of research to show that it's harmful. So I kind of go with the, if it's helping the child, then it's worth continuing to try it. But if you haven't tried it, I'm not sure I would recommend someone investing the resources, because sometimes it's not covered by insurance and this can get pricey. I would rather the family use the resources somewhere else, like getting into a pool or something similar to that. And then the last slide that I have is a lot about just water, just getting in the water, just playing in the water. If you have access to a pool, that is really important. You can make it play games. You can have, they have these little like arm wrist things, which will act as weights in the water, because the drag in the water helps to increase the muscle strength, and just making it fun and playful. But again, that is only limited to the summer months in certain areas. So you can do the best as you can. Sometimes I know there are certain times when pool, if you don't have access to a pool, like a community pool, some hotels, I don't know, it depends on the region and depends on the hotel chain itself. If you go to the hotel that you know they have an indoor pool, sometimes they will allow you to come into their pools to use for kids with in needs. But what I'm hearing more and more these days, actually, that they're not doing it because of liability issues or not. But there is another organization called Swimly, which is similar to an Airbnb, but it's Swimly. It's a Airbnb for pools. So I have had one or two families that have rented a pool for a couple of hours, so their kid is not in a public environment, and then been able to do it. But again, that gets pricey, and it does take resources. But water is the best. We really, really encourage use of water. Next slide. Oh, some more. Oh. All right. So going back to what Lindsay said, it's really, really important to recognize overwork, extreme fatigue, muscle cramps, and behavioral outbursts. So a lot of times I have parents ask me, how much should I have my child do XYZ? I don't have an answer for you at the moment, because I don't, I think mostly you have to see your child's behavior pattern. You know your child best. So today you went out, you had a family picnic, you're all hanging out, enjoying, and then tomorrow they are so tired that they choose quiet-based activities. They want to play on their phone, they want to read a book, they want to just lie down. So that kind of gives you an indication that yesterday, that the day that you had the family picnic was a little bit too much activity. So then you have to kind of moderate. So as a parent, you may have to step in and moderate them. Like Lindsay said at the pool, there's that automatic like 15-minute timeout on an hour basis. So you want to make sure that you kind of make sure the kids kind of moderate their activity so they don't overwork. And then regular outpatient PT is not likely indicated. I'm a big believer in that as well too, that you should have functional goals. Just you just doing PT ongoing once a week forever may or may not be helpful. So if you have a specific functional goal, then maybe that would be the most appropriate time. Do like an episode, like 3 to 4 times a week for a couple of weeks to be able to achieve those goals. But rather than doing regular outpatient therapy, find a activity that is more kid friendly, whether it be adapted sports through Special Olympics, or sometimes karate and martial arts will have dojos that will, the sensei will work with kids with disabilities. So just other activities that will be helpful. School-based PT is always there, but this, again, the school-based is based on the needs of the school. Can you get to class? Are you able to pay attention in class? Do you have the strength to sit in a chair for extended periods of time to be able to pay attention? So it's all educationally related. And so they may or may not provide services after a certain time. And whether it's in class or pull-out services, that is kind of dependent on the child. And then last but not least, no lifting weights, avoid resistance exercises. And we keep talking about it over and over again, because those are the things that we really want you to highlight, to walk away from, especially is to minimize the eccentric contractions and then resistive exercises. And again, we are a big believer in kids being kids. So if they, if they have an activity that they really enjoy. So for instance, I just had a young lady and she wants to be on TikTok. So we practice doing TikTok videos so she can, get on TikTok. So we kept her active, she's moving, and she made a TikTok out of it. So next. So this is our summary slide. So exercise is individualized. We really focus on water-based activities, monitor for overuse. Passive stretching has been helpful, but also, as Lindsay told you early on, is to not beat yourself up and do not feel guilty if you see the contracture continuing to progress. You do the best that you can. And then orthosis and bracing, daytime and nighttime wear if it's tolerated. And sometimes kids just, as they get older, they are old enough to make some decisions, and they will say, I don't want to do it anymore. And we have to respect that. And I do. I had a young lady who's 20. I mean, she's older. She's old enough to make a decision. She just said, I'm not going to wear these AFOs. I'm not walking. I'm not going to wear it. And we go from there. So equipment and positioning, again, it's very important, and it's to promote independence and to maintain range of motion and manage pain. So those are and that is it. That's the last of our slides. And if you have questions, and I see some questions in the chat box.
If you can put your questions in actually in meeting polls, that would be more helpful. So first question, can you demonstrate the difference between eccentric and concentric? I think it's very easily to mix those up.
Yes. Am I on a camera? Okay. So a concentric contraction is when you are contracting the muscle and that muscle is getting shorter. So the biceps kind of the easiest way to think about that. For your quadriceps muscle, it's if you're, straightening your legs, so that muscle is getting shorter. Eccentric is the opposite movement. So you are holding, you've got that nice big contraction and you're letting your muscle get longer. So if you kind of think about it as you've got a string at your joint, is that string getting smaller or is that string getting longer? So eccentric is when it gets longer.
Perfect, thank you. I'm going to modify this question a little bit. When is it not enough to wear AFOs only during the night? Like, what are the indications between kind of starting to need them during the day versus only at night?
Good question. That's a hard one to answer. Well, I'll start and you guys can jump in if you have things to add. So similar to what we heard in the orthopedics. So I'm not going to say that there's a cutoff or a specific time or range of motion that you need to consider. It's looking at the individual. So what is current functional ability? So if this is a person that's walking and they are wearing night splints and we're still seeing some tightness at the ankles, let's say, sometimes that can be useful to have some of that contracture. There are times, as we saw in Mariana's video, where those contractures can get to be too tight and they're making it hard to walk. there's, so I guess my long-winded way is saying we're trying to balance contracture management with function. So if you get tightness, that doesn't mean you aren't being functional and you're not still achieving your goals. So they're not the worst thing that can occur in the world. But then there are times where those contractures are progressing and they are making that function harder. And so that's when we may have conversations about more bracing or other potential options for contraction management.
Lindsay, can I jump in?
Yeah.
So to piggyback on that is that supposing the person's contractures are getting worse and you need to help them do a stand pivot to transfer to move from one position to another position, that would definitely be an indication to wear the braces in the daytime to be able to do the transfers. Otherwise, if their contractures are so bad that their feet are not flat on the ground to be able to allow the family member to do a safe transfer, then that would be an indication to be using it during the daytime.
I don't know if I can talk here.
Yep.
I think we have to think in two situations because we have the functional contractures and the management. In my experience, Brazilian experience, is different because when we have a muscle that is shortened, but it will facilitate the function, we'll look to this contracture with, more, not more careful, but, we will understand that these contractures actually provide the function, so facilitate the function. For example, gait in toe gait is walking. Sorry, it's a plantar flexion gait. So it's this kind of walking is used to maintain the function, or even elbow contractures. So the patients adopt because it's easier to do the movements. For example, hand to mouth, because they don't have to do the movement and all the arc of movement, the amplitude of movement. But when we are talking about the other situation, when the contracture is impairing the function, I think we have to consider it a night space. And it's not a consensus about how long we have to use them, but I have really good experience when I use more than 6 hours per day. Actually, not a day, sorry, at night, no in daily time, but in night time. So I know it's tough, but it's a very good way to maintain the length of the muscle.
We're taking questions in the room too.
No, we're not taking questions in the room, you guys.
Oh.
Well, you guys, can you put up the slide for meeting polls one more time so people can grab that URL? We actually only have about 5 minutes. Can you talk about the difference between exercise and dystrophy versus myopathy? Some people are wondering in the myopathy space, can we do free weights? Can we do more intensive therapies versus in the dystrophy where you're maybe more concerned about muscle tearing?
Good question. The answer is we don't know.
Yeah,
So
exactly.
you get to be, your human body and how it feels. So, as long as you're doing it I would recommend doing it in a supervised fashion. That may be one of the times where maybe you have a bout of outpatient PT where you try out some exercises, you're monitored, you're kind of watching strength and function over time, as well as your fatigue, pain, all of those things, increased muscle cramping. Assuming you're not seeing any of those side effects or negative side effects, then we would say that that's not something that seems to be harming your body. So go with it. If you do start to see, as Mina said, those increased muscle cramps or pain or just reduced increased fatigue and reduced energy, darkened urine, those sorts of things, then that would be a sign you're doing too much. So stop that.
If it hurts, stop. If you're too tired, stop.
Listen
Yes.
to your body.
Yes.
Yeah, we have to avoid the overtraining. I think it's difficult because each kid will be a trigger or linear, but we have to. That's why we are here. So we have to identify where is the signs and when is overtraining, and can be represented by pain, as Lindsay told us, and maybe more time to do the activity, and respiratory signs.
So can you talk about the difference between joint movement and stretching and how either or both are useful?
So, sorry, Mina, do you want to answer questions? I feel like I'm just jumping in.
No, that's okay. Go ahead. Go ahead.
Yeah, so when we think of stretching, so joint movement would be movement at the joint in general. So when we think of stretching, it's when you get to that point that your joint is no longer moving and you're pushing into that. Or think about yourself. I like to wear heels, although I'm not wearing them today. Sometimes my ankles get a little tight, and so I can actively stretch by pulling my toes up and my ankle into that stretched position. So it's kind of moving beyond kind of that end range you're feeling. So when you are doing movements, you are moving your joints, but often you are actively stretching your body too. Thinking about walking, I'm stretching my hip flexors as I take steps, but I'm also moving that joint through its range. Hopefully that answers the question.
When we do, or you do the stretching exercise, we are not training the muscles. We only train the muscles and stimulate the muscles when we actively move the joints to promote a movement. So I think one important difference between passive exercise, that is stretching, and active, that is joint movement.
Just a real quick, I know that a lot of times families will say that I'm doing passive range of motion, so they're getting stronger. The only person that's getting stronger is the one doing the passive range of motion. So as Mariana said, that in order to strengthen, that child has to move to activate the muscles, and that's when they're going to get stronger. So important to remember that.
Okay, 2 more questions. How soon after Achilles tendon lengthening surgery can we start stretching? I know there's no one size fits all, but
Multidisciplinary team approach.
Yes.
So we do want patients to start moving as soon as possible, but stretching, you need to let that joint heal. And so I won't make any specific comments, but just say it's a conversation you have with the orthopedist and your multidisciplinary team.
Depends on the surgery also, because spine surgery have specific recommendations, but shortening surgeries others. But the recommendation is to stimulate the mobility as soon as possible, but we have to talk with the orthopedic surgeon to have this approval,
okay. Last question. Sorry, guys, I know we could be here all day. This is an amazing session. We appreciate the 3 of you. Is quarterly physical therapy enough?
Can you elaborate?
Our child does physical therapy only once per quarter based on team advice. Is that enough? Is that helpful? Is that doing anything?
Depends. Your favorite answer. Never. So you do not have to go to physical therapy 1 time a week to have good outcomes. So if there is something specific that your child or you are having difficulty with, that you, as Mina was saying, an episode of care where you're really working toward that goal, maybe this particular transfer has gotten challenging, or eating dinner, getting food to the mouth has become challenging, you can work with that therapist to come up with management strategies or alternative strategies, supports that can make that easier to maintain that independence. If you don't have an active goal, you're just kind of in a maintenance phase, you or your child is doing great in daily life, you don't have to add PT to your to-do list just to tick a box. So living your life is just as much physical therapy as going to a physical therapist. So that physical therapist is really there to support you, make changes, help find supports, but it's not that you have to go and see them, or there'll be a significant change in disease progression or contractures.
If to build on that, if your child is being followed on a quarterly basis, I would probably ask that they do or just monitor certain specific tasks on a regular basis to make sure that those tasks that they're able to continue to do. Whether it's a specific test, I know if you're ambulatory, maybe it's a 6-minute walk or a certain test, or could it be, is your child able to transfer by themselves, and you monitor that every time, then at least you know whether there's been a change in function or change in their abilities, and that would be a reason to step it up. So if they were able to do a transfer independently and now they're not, on the next quarter, then you can say, well, maybe this is a time for us to increase the therapy services. But if they're continue to do those certain tasks, then as Lindsay said, then just monitoring on a once a quarter basis could be enough. So
Great. Well, thank you very much, ladies. We
Oh,
appreciate
thank
your
you.
expertise.
Thank you. Thanks.
And for those of you here, we're still here, so happy to answer
Yeah.
any more questions.
We'll be back in here at 1:30 for nutrition, followed by pulmonary.